Hello.
Very good evening, sir.
Good evening. I just am wondering whether I'll be able to make any contribution, because this seems to be a very new technology.
Sir,
Uh,
you can try and share your presentation, sir. I'll help you.
Now, presentation means
Do you have something to share, sir?
well, I wish this meeting a great advancement in teaching of urology. More
Sure,
than
sir.
that, it's many years since I have retired from government service and then
Yes.
practice also. But still, it is very nice to see that so much of advancement has been made, and
Sir.
people are able to follow so many
Sir.
things.
Yes. Sir, we will be starting the program at 7. Your voice is perfectly clear and audible to all the audience. And
Okay.
I'll inform Dr. Arun Chawla, sir, that you are here, sir.
Okay.
Yes, sir.
Okay. Thank you.
Welcome, sir.
ಏನ್ ಜಯಂತಿ ಅಷ್ಟ ಅದೇ ಮಾರಿ ಅವನು ತಟ್ಟಿ ಮಾತಾಡಿ ಇಡ್ಬೇಕಾಗ್ತದೆ.
Arun? Arun?
ಹಲೋ.
Archana?
Yes. ಇವನು ಚಲೋ ಬಾ.
My computer is giving some trouble. I want to talk to.
Talk to.
Very good evening, sir.
ನಾನು ನಿಂತಿಟ್ಟೆ.
Very good evening, sir.
ಹಲೋ. ಗುಡ್ ಈವ್ನಿಂಗ್.
Dr. Arun, sir, has not joined as yet, sir. I am calling him, sir.
Okay. So this is to start at 7 o'clock, 20 minutes
Hello?
more.
I have opened and
I don't know.
Now what do you do?
You are talking, asking me.
Hello?
I can see you now, but hi,
Chinna?
Solu, I can see
Soluka.
you. Can you see me?
I can see you only with big letter Chinnaswamy see
I
on the
see
main
you.
screen. I don't know what I'm going to do, but I'm not able to understand what is going to be done.
No, I think in another 7 o'clock, the connections may come.
I know, but they're supposed to help me how to load my slides. Which unfortunately by the time I
Slide,
did it, it became all confusion.
slide எல்லாம் ஒண்ணும் போடல சும்மா படிக்கிறது தான்.
Slide போட்டேன் அதான் தப்பு பண்ணேன். I
Yeah.
can talk. Hello Sanjay. How are you? Can't hear you, Sanjay. Yeah, unmute yourself. Sanjay, unmute yourself.
Yeah. Okay, sir. How are you?
I'm getting on. Not happy as far as this is concerned. I don't know how to download my slides, etc., etc., etc. And Arun told me he'll do it, but he's missing now.
So can I share my screen for a minute?
Even if there's no slide, doesn't matter. I can talk something on the external.
Yeah.
Sir, good evening, sir. Good evening. Dr. Sanjay. Venu, sir,
Yeah.
good evening.
I can only see your face is very not clear. Arun.
I'll do some changes, sir. 1 minute, sir. It's because of the light. Dr. Keshav, good evening.
Good evening, Arun. Good evening, sir. Good evening. Happy Teachers' Day.
Hello.
Hello, Keshav.
Good evening, sir. How are you?
How are you?
I'm fine, sir.
Whose side is this now?
These are my slides. Can you see them?
I can see that.
Yes, it's a nice, clear, sir.
My side, I don't think I'll be able to show. It doesn't
Thank
matter.
you. I will stop sharing.
Navneet?
Yeah.
Navneet, PVG sir का slide का थोड़ा issue आ रहा है. He is not able to share it. Can you guide him? Just.
Sir, he can email it to you or me and we will play it from our end.
I can't understand anything you're telling.
Nini sir, he is telling if you mail him, he can run the slides from here and you can speak.
I sent the slide to you, send it to him.
Yeah, I'll send it to him. Okay. Navneet?
Yes, sir.
I'm sending his slides to you, okay?
But then I have to say every time next slide, no?
Yeah, that is true, sir.
That is going to be a bigger thing. I think I'll skip the slides.
No, sir.
I want my first 10 slides and after that I'll go whichever way I want to go.
Navneet,
Did you get it?
Navneet, can you check it?
Keshav.
Yes, sir.
All
Yes,
these
sir.
are new gadgets, man.
Sir?
Old horses cannot be taught all these things.
No, sir. You are veteran in Zoom meetings.
No. I know present slides.
You are not presented.
I only
No, sir,
listen
you
to
will have
your.
to keep it. No, you have to keep the presentation open on your desktop, then share the screen, then
I
it will
have
ask you to click on that. You have to keep the presentation on the desktop.
I've got presentation on my desktop is there.
Now see, he's shared it.
Oh, okay. Now what do you do?
You just have to tell him next. He will
Not
change the
opening.
slide.
Once you open it, I'm not opening it. And my computer hung again.
No. Navneet will share your.
Ask him to take the slides off, please. Otherwise, it is getting hung. I'm not able to get into Zoom at all.
No, you are heard, sir. You are
I
heard.
can't open it. I can't open it, man. You can see me, but I can't click on the Zoom doesn't work.
No, you keep it on your laptop, then share the screen.
I kept on my laptop, man, but on my
Navneet is
desktop.
Dr. Venugopal. Navneet, is Dr. Venugopal made co-host?
See, what has happened is the thing is hung.
Yes, sir.
Hmm?
I can't do anything.
He is the co-host, sir.
Huh?
No, make all the panelists today speakers as co-hosts now only.
I
So that they
can't do
should not have
anything.
problem.
I can't do anything now. Everything is stuck. I can see you, but I can't do anything.
You will have to log in again, sir, if that is the case.
Let me see. No, it's not closing, man.
See, you can't see a share screen, green color share screen at the bottom.
I am not able to enter at all.
Then log out and then log in.
I'm only seeing the front page of my desktop.
No, log out and then log in.
Log out means not logging out also. That's the trouble.
Hello.
No, just leave the meeting.
Hello, Arun.
Good evening, sir.
Good evening. Can you hear me?
Yes, sir, we can hear you loud and clear.
I'm checking. Okay.
Sir, if you have slides, please check your slides, sir. Slideshow.
So can you allow me to share the screen?
Yeah. Navneet, make them co-host, no?
Sir, he is the co-host, sir.
NP Gupta, sir.
Yes, sir, he is the co-host, sir.
Sir, you can share the
Okay.
screen.
Okay. Should I join now?
Yes, sir.
Can you see?
Make it full screen, sir.
All right.
Yeah, all right. Move that. Okay, that's fine. That's fine. You can stop sharing,
Okay.
sir. That's fine.
Okay.
Yeah, that's fine, sir. CC sir is there.
Hello. कौन बोल रहे हैं?
Arun, is CC sir? I can see on the panel, but is he there?
अभी बेटा इस समय मैं बिजी हूँ. कल सवेरे हमारी ओपीडी है. कल वहाँ बात करिए.
He was there and he was talking to us, sir.
Hello.
Sir.
Hello.
Good
Yeah,
evening, sir.
Good evening. Good evening.
Sir, you have any slides?
No slide. No this thing.
Okay.
I just
Then it's
say
fine.
hello.
No, then it's
I
fine.
Okay,
just
sure.
say hello. Yes. Okay.
No. If you have slides, we wanted to just check. Otherwise, it's no problem.
No slide.
Okay, that's fine.
Very good. Right.
Venugopal sir, can you share now?
So he don't have to share the slides.
Venugopal sir, unmute sir.
Mute. muted me. Can you hear me now?
Yeah, we can hear you. You click on share screen.
Share screen. But I have not opened my thing.
No, you have to open your presentation on the laptop. Minimize this and open the presentation on the laptop. It should be on the desktop.
No, desktop only. Open it. It has now come. See, the moment I do it, Zoom doesn't come.
So we will play it, sir. You just speak. That is all. We will play the slides.
Zoom doesn't come, and the moment I open my slides, Zoom is dead. I will restart the whole thing again.
Good evening, Mahesh Desai, sir.
Anyway, don't worry. I'll restart again and come back to you.
Okay.
Hi, Venu.
Good evening, sir.
Good evening. Good evening. Venu.
How are you?
Good, good. Good to see you.
I think trying to do something for my slide, I'm not able to do. I'll talk extra, but don't worry.
Hello, Keshav Murthy.
Good evening, sir. How are you, sir?
Arun.
Sir, good evening, sir. Happy Teacher's Day, sir.
Nice to see you. After.
Sir,
Gupta ji.
Good evening, Mahesh bhai.
Good evening. We just met last
Nice to
week.
see you. Your screen is looking very good.
Yeah.
Good evening, sir.
Good evening.
Good evening, Gupta sir. Good evening, Desai sir. Good evening, Dr. Chawla. Good evening, Dr. Keshav.
Ravi, good evening.
Good evening, sir.
Good evening, Ravi. How are you?
Good evening. Good evening. Good evening, Dr. Sabnis. Good evening, Deepak.
Good evening.
Hi, Sanjay.
Hello, sir.
Hi, Sanjay.
Sabnis.
Nice to see you. See you, all of you, sir.
Sabnis.
Good evening, sir. Good evening, Sanjay sir.
Venugopal sir, you have to unmute.
Can you hear me now?
Yes, sir. We can hear you. We can see you.
Don't go to slide at all. Forget about it. The moment slide is open, my computer is getting busted. I'm not able to do that. I mean, just forget about it. I'll give something.
Sir,
Don't
have to play the slides. You just see the slideshow.
That is not happening because the moment I open the slide, the whole thing gets hung.
No, you don't open the slides. We will open it for you. You can see the slideshow and speak. We will open it for you.
Okay.
Navneet.
Yes, sir.
Dr. Venugopal's, when it come, you play the slides. He will speak. He will see that and speak.
Yes.
I'll go on to the exercise. Okay.
Yeah.
Gupta ji. Gupta ji.
Hello, sir. Good evening.
How are you? Long time.
I'm fine. I'm fine.
Nice to see you.
Thank you, sir. Same to you. And my gratitude to you being my teacher also, I can say like that.
When did that happen?
Dr. Chinna Swami was my examiner for MCH.
I know that.
They do well?
Yes, sir. Doing fine.
Is Chinna Swami there?
Yeah,
He's
I'm
somewhere
there,
in the-
but,
Hi, Nitin.
Nitin,
fine, I'm fine.
Then, sir, you have to unmute.
Good evening, Dr. Desai. Good evening to all my teachers. This is Gopal
Good evening.
Krishnan.
Hi,
Good
Gopal.
evening, Gopal Krishnan.
Arun Chawla, sir, do we ask a question to our teacher at the end of the presentation?
I don't think
Thank
this
God,
is
no.
the questions. You can just thank them, and if you have something to say, you can say.
Only
I
teachers can
promise
ask
you,
questions.
Don't
I
joke
promise
about
you,
it.
it will only be a it'll only be a philosophical question.
You can
Yes,
put comments.
Sure. No problem.
Hello, Subhash.
Yes, sir. They have given answers for several years. Now you have to just listen to them.
Only teachers can ask questions.
Well, we still have a lot to learn from them. That learning never ends.
Yeah.
Even we are learning every day. And now we are learning from our students.
That's right. I think we are learning from grand students now.
Well,
Yeah.
there is a saying by William Osler. It says that the day a doctor stops learning, that day he dies.
Yes.
Yes.
And quite a lot of us are dead already.
I think time is up.
Ravi,
No,
we have
no,
2
sir.
minutes. Can you just
2 minutes.
Arvind has joined. Arvind Panda.
I'll call.
So who is giving the timing?
No.
So we can unmute. We can unmute, and only person who is speaking can unmute themselves.
Sir, all faculty will be just on unmute and video on, sir.
Yeah.
Good evening, everybody, and welcome to this special program being organized by the Indian School of Urology and the auspices of the Urological Society of India. Today is September 5th, which is the Teachers' Day, and we thought we will commemorate this day by inviting all our legends in urology. You will find all the legends in urology speaking to us on the topics of their own interest, and it would be interesting to hear them with loads of experience which they have carried for the past years now. They've been teaching us. There are youngsters who would join in, who would know these legends in urology, who would speak on these topics. To start this program, I would now invite Dr. Arun Chawla to welcome all the panelists, and then we will ask Dr. Sabnis to give his opening remarks. Over to you, Dr. Chawla.
Thank you, sir. अखंड मंडलाकर व्यापते येन चरणचरम तत्पददर्शित येन तस्मै श्री गुरुवे नमः. Good evening to all the teachers, teacher of teachers, my dear friends and colleagues. The light of the world, the beacon in the dark, and the hope that gives us strength to survive is our teacher. And today we celebrate Teachers' Day, a day kept aside to honor the gifted souls who work, guide, mentor us every day to make sure that our future remains bright. A very warm welcome to all the teacher and teacher of teacher, those who are a faculty for today's webinar, Professor P. Venugopal, Professor Chinnaswamy, Professor Desai, Professor Dinesh Kumar Krishnan, Professor Narmada Gupta, Professor Sanjay Kulkarni, and Professor Nitin Kekri. Today, in this webinar, all will be talking on a theme or some issue from the long journey of many years in urology, and would like to share these valuable tips and lessons with us. With this, now I request Dr. Sabri, President Urology Society of India, to give his presidential remark, and then we begin the webinar. Over to you, sir.
Thank you very much. And I must congratulate you and Dr. Keshav for organizing this program. It's a perfect respect to our teachers, and what a day to remember what teachers have done for us. Well, Urology Society of India, when it just started with few people. And those few people actually took a lot of struggle and struggled themselves to make sure that society grows. And in that way, the urology actually grows. And today, after 55, 60 years, we know that we are tasting the fruits of the struggle which they took for so many years. Well, urology was established in India and then it flourished. But these are the people, today we have called, there are many teachers in USI, but these are the representative of the teachers in USI. They are the ones who have taught so many people. For decades, they have taught so many people. And
Sabni sir is not heard.
Sir, volume is there.
I don't know, suddenly it went up.
Yeah, please continue, sir.
So I think we are ready to listen to them. These are the topics given to them because they have worked passionately on those topics, and they have struggled so much on that topic to get the information. They have mastered that topic, and today we are going to listen from them. I know urology, when it started, that when we were students, there was no endovision camera and we used to see through the teaching attachment. That was an extremely difficult period to teach urology. But during that tough time, these are the mentors, these are the teachers who have taught urology, not only the art and skill of urological surgery, but most important, the concept of urology they have taught. And that is how the urology has really grown across the India, and not only grown, but it has flourished across the India. I think today is the right time to pay respect to them and to admire them. And I must congratulate you for organizing this program. I think we are ready to listen to the legends, as rightly put by Keshavamurthy, and we will be, I'm sure it will be very helpful to everyone who listens to them. Over to you, Dr. Chawla. Thank you very much.
Thank you, sir. Amin, are you there online? Arvind? Okay, so we start our program, and befitting way to start this program is to invite the teacher of teacher, a legend who has his journey in urology of more than half a century, years of more than half a century. So may I have the privilege to invite Professor C. Chinnaswamy to speak on my journey as a teacher. Over to you, sir. Chinnaswamy sir, are you there? Navneet, can you check just?
Sir, this link is broken, sir. He's not here.
So anyway, we'll wait for him to join back again, and we'll move on to the next talk of the today. That is by none other than Professor V. Venugopal. May I invite you, sir, for your talk on my journey in pediatric urology over 5 decades, sir. Over to you, sir.
Can you hear me?
We can hear
Yes,
you
sir. Yes,
loud
sir.
and clear.
Very clear.
I must thank USI for the opportunity given for me to speak something on my favorite area, pediatric urology. I think I started this long ago, and maybe over 52 years, I have seen the various advances and various nuances that has developed into the area of pediatric urology. Next slide, please. Next slide. I think I should bring one point to the question. No, don't change. Go to the previous one. Go to the previous one. I think Subnis mentioned something about formation of urology, and it was done way back in 1960. And the first meeting of this section was done in Velu in 1961. What is very important for us to realize is we were christened as Urological Society of India only in 1977, and subsequently we became part of, separated from ASI only in 1988. Now, the most important point that Subnis, which I want to emphasize, is that Dr. B.N. Kolawala has done so much of urology in the formative years and for many, many years subsequently. Do we have any award on his name? I have to say no, sadly no. And I'm sure Subnis and his team will make it a point to see that his name is perpetuated and kept in the urology forever without forgetting. Next slide, please. There are several people who trained me and made me what I am today. And one other person is my father, of course, Professor C.K. Menon. He was a very good surgical craftsman as well as a very good teacher. I think he gave me the seeds of teaching as far as urology is concerned. Next slide. Next slide. Professor Raghavacharya, next. Next. Professor P.K. Warrior, next. And of course, my Guru, Dr. H.S. Bhatt. These are all people who mentored me and made it possible for me to what I am today and having some say in whatever activities USI is doing. Next slide, please. My interest in pediatric urology started just prior to my joining MCH urology. And when the interview, after my MS, I was waiting for a call from Velu for my MCH. At that time, I had the opportunity to work with Professor T. Rajan, an eminent pediatric surgeon of those days, and he sowed the seeds of pediatric urology into me. Next slide, please. I went to UK on a pediatric urology senior commonwealth fellowship, and my coordinator was Professor John Sidney, and I had my training essentially in Children's Hospital at Newcastle, where I worked with Professor J.E.S. Scott, and I learned a lot from him as far as pediatric urology is concerned. Next slide, please. I'll be failing my duty if I do not pay pronouns to my colleague, whom I frequently call a Shah, who helped me throughout my career in bettering my skills in pediatric urology. Thank you very much, Shah. Next slide. Next slide. Previous slide. Previous slide, please. In my travel to pediatric urology, I have seen many developments occurring and from 1966 to almost today. During these days, I commenced interest in pediatric urology. Many of the present concepts are non-existent, and this talk highlights the way we manage pediatric urology cases then. Most of the current thoughts are well known, and repeating them will be like taking dignity to the Navy. Next slide, please. Next slide. It is practically possible for anyone to cover all aspects of pediatric urology in the brief time that has given to me. Even now, I think I might rush through many of my slides because it is not possible for a lengthy talk in a 15 minutes time. Next slide, please. Postal wall, PVUR and PUG are the areas where considerable amount of advances have been made in the recent time. But I am not going to the whole gamut of all these things. I'm going to restrict myself to briefly to postal wall and also to VR to some extent. Postal wall is very, I'm very fond of this condition, postal wall, as I had the privilege to treat over 1,000 cases during my span of my life in urology. But I started my treatment in those days, in 1966, when we did not know much about postal wall and what it entails. Next slide, please. There are several procedures that have been done in the past, and most importantly is those days for any such situation in and around the bladder neck used to be sacrificed. This was one of the things that used to be done with, the reason why it was being done, I have no idea about it, but it was being practiced liberally. And one instrument that we used to have was called a bladder neck punch, which I think people who are from Vellore may remember that is the only instrument probably the whole country had, called bladder neck punch, and we used to punch out the bladder neck with that instrument. My way of tackling postal wall in those formative years were using peritoneal urethrostomy, performing a peritoneal urethrostomy, bivalve ENT spectrum was used through the ureterotomy, and catching the walls by plastic surgery hook and snapping therapy. Now, this appears cumbersome, but it yielded good results as far as patient voiding is concerned. Next slide, please. Next slide. Okay. Don't please. Now, why are we having this problem at that time? One is lack of administration equipment, endoscopy equipment. We did not have any, and we had only large size instruments, maybe meant for adults, and the smallest scope available subsequently was research scope was 10 and 11 French instruments, and this was a very difficult thing to do. Used for infants and neonates. Most of our patients presented late in age, and only personal diagnosis was possible as an ultrasound was not available those days. Next slide. Next slide, please. At KMC Manipal, where I was working for about 26 years, I was privileged to have all fiber optic scopes by 1974, and we started ablating wall by performing peritoneal and introducing and ablating wall for the vision. This was done because instruments are bulky, as I told you, 11 French instrument scope was too big to be passed into the urethra of a newborn or an infant or even neonate. But definitely, though we did a peritoneal urethrotomy and perforated or resected the wall, they did improve the prognosis considerably. Next slide. Next slide, please. Those days, upper aortic diversions were a standard practice whenever there is evidence of some renal failure in the patient. Now, when you find such situations, you go and take off the upper aortic diversion, and these children were subjected to follow-up and treatment subsequently. How long should we keep the diversion was a big controversy at that time. Next slide, please. The first paper from India on PUV, as per my understanding, was published from CMC Vellore in 1974 by late Dr. Colonel Mohan Kumar, along with Mohan Rao and late H.S. Bhatt. There are so many other studies that are coming, but most important thing is even till early part of 2000, the articles from India were coming out saying that cutaneous urethrostomy is still a preferred method for primary treatment till the child stabilizes, and then you will do some what are necessary as far as postal wall is concerned. Next slide. There are so many disadvantages to, many techniques available for doing urethrostomies, and most of them were loop or endourethrostomy, which was not a good procedure according to me, because it left a lot of side effects as far as the patient is concerned, which was difficult to rectify subsequently. Next slide, please. I prefer Tauber's Roux-en-Y technique for my urethrostomies, and I found it very useful. And undiversion at later stage, when required, was not very difficult because the urethral continuity was present. Next slide, please. Subsequently, in 1992, Moore came out with a unilateral refreshing urethrostomy, which changed the whole scenario. Of course, by this time, the upper tract urethrostomy was receding because more and more equipments are available, miniature scopes are available, and more endoscopic procedures could be done. So cutaneous vesicostomy was not very considered very essential. If at all anything was been studied, I think it was cutaneous vesicostomy that has been practiced more and more, and the urethrostomy receded to the background. But the most important thing in all these things is, whatever type of the diversion, the upper tract diversion you do, the most important thing is there should be a recycling in the bladder, otherwise the bladder contracts and becomes very difficult for subsequent management. Next slide, please. Many patients with PUV will ultimately end up with renal failure, and this slide depicts that what percentage of renal failure can be expected in these patients. And in the past, majority of the renal transplant pediatric ISU were patients who deteriorated after treatment or without treatment, whatever it is, were deteriorated, and then went into renal failure, for which a renal replacement therapy had to be performed. Next slide, please. Next. So the question comes is PUV a bivalvular disease or is it a univalvular disease? Though we all know and teach and preach that PUV is a bivalvular disease, has got two valves fused together, and that is the reason why the urine flow is not there. But Baskin and Krishnan has found that it is only one leaf, and the change that the appearance that you get of our two leaves is because of the instrument being passed or catheter being passed. This is their theory. Poppermus, Paltevan has accepted this concept, but instead of all these new strategies, we are still to accept and continue to consider the UPE as a bivalvular disease. Next slide, please. Dilated ureters were known for a very long time, and probably even as early as 2nd century, Galen has described some dilatation in uterine children. Now, is your disease? Is it a phenotype or disease? It is not. According to Jatin Bhandari, in 2017, he says that VER is not a disease. RDU and sentiment attacks were available at that time in early days itself, but today we don't go into all these things, and even IVU is being given up. In children, most of the investigation that you need is a good ultrasound, if performed well, and radionuclide studies were available, and radiological procedures must be kept in a distance as far as this is concerned, because most of the children will have to have repeated radiological procedures, the investigations, and that is going to add on to the radiation exposure the child is going to have. Next slide. In most of the cases, excepting obstetrical ureters, we were treating the patients with antimicrobials we had at that time. Now remember, are we returning back to those days? Because today, many of the patients with refracting ureters are on antimicrobial therapy, whether it is prolonged therapy, and some people have recently come out and Antibiotics need to be given only at the time when the infection is persisting, and one can stop the treatment of the antibiotic afterwards. But majority is still believe that it's better to continue antimicrobial therapy for a longer period. In 1952, Hatch made a profound statement. As I told you, in the past, we were doing bladder neck cutting and bladder neck for incident very commonly for PUV as well as for VUR. What Hatch made a profound statement is, do not spoil the virginity of the bladder neck. But even in 1960s, when I started urology, bladder neck was demolished with impunity. Many cases of obstructive large urethra that we had at the stage at that time underwent dome reimplantation and not the concept of tunnel reimplantation. The concept of tunnel reimplantation did not exist in 1966 in India, though it was being done from in Western countries. It was being done for VUR. Next slide, please. Next slide. In 1968, Hendren visited the department in CMC and demonstrated lead-metropolitan reimplantation with package modification. And this was the beginning of tunnel reimplantation in Vellore, I should say probably in India. The first tunnel reimplantation thereafter was performed by me at Vellore. But the important point is, we did not know what tunnel reimplantation was, even though it was being practiced earlier. Lead-metropolitan and all these technologies were available earlier, but in India we were reluctant to do all these things, and we did not proceed doing tunnel reimplantation till late 1960s. Next slide. Now, there are several techniques of correction of URI from early 1950s, but I'm not going to go into the details of all these. Why it is. In my experience, I have been performing lead-metropolitan with package modification for a long time, since 1972 or 73 or 72 onwards. And later on, I took up tetrasaraphy for those patients where extravesical tetrasaraphy for those patients where the ureters are not large but needed surgical intervention. Today, if you look at it, how many of these non-dilated, not so largely dilated ureters need reimplantation? It's a question that's coming up in a big way. Now, Rich Krieger is a procedure that we used to practice quite a bit. But when you do it bilaterally, you must be very careful that the peritoneal connection to the dome of the bladder and the base of the bladder should not be disturbed completely, and it's not pushed off the peritoneum.
Okay, then.
But if you do it, it is going to create a problem of neuropraxia. Next slide, please. Now, I'm not going to go into all the details. This is what I called and taught everybody as 10 commandments of reimplantation. Now, I've given all of the 10 points, but time will not permit me to go into discussion of each one of it, excepting that the 10 commandments involve ureteric length, how much is the internal length required, how much is the diameter of ureter required, and what are the situations this may not be possible. Next slide, please. Next slide. Because these are all things that comes automatically when you start teaching for a long time, and you find so many technical points which have to be borne in mind when you're doing the reimplantation. Next slide, please. Next slide. Again, the same thing. Next. Next. Now, sleeve resection is something that one undertakes occasionally. Now, it is mostly taken in obstructive large ureter, non-reflexive large ureter, rather than for sometimes a grade 4 or 5 reflux can also have a fairly large ureter. Sleeve resection should not be undertaken if the ureter after disconnection becomes less than 1 centimeter in size. There is no necessity for sleeve resection. Usually, the term megaureter or large ureter is applied to a situation where the ureter is more than 7 millimeter diameter. But this is not very correct, and I think this is making it look a little more, for us to have more cases, probably we are taking that decision. Now, there are many ways of doing civil section, but the most important thing is what Hendren has described, and probably the civil section is a very good method for narrowing the ureter sufficiently enough to place it the proper tunnel with the proper way. A large ureter in a tunnel in a child will be very difficult. So maybe some of them may have civil section. Next slide, please. Next slide. John
Sir, a few
Latimer,
minutes left, sir. Sir, a few minutes left, sir.
Okay, John Latimer was the one who decided that refluxing ureter high and low grade depending on the presence of reflux at which stage of failure. Now, these are the things that you must understand. Leibovitz, who described grading, described each grade into three, and ultimately it was the International Society, International Group, a VR group that condensed the whole thing and made it what it is, what we understand today. Next slide. So this is a distance summary which I want to show all of you. This patient was operated by me in 1974 and came to me for follow-up, came to CSD, came to Manipal for follow-up 48 years later. And after all the things that I have done on him, he still got a fairly decent function. And that's something that I always pat my back for the success that I could give for the state. Next slide, please. All these are well known to most of you, so I'll just skip the slides. Next one. Next one, please. There are so many gray areas as far as VR is concerned, and which most of you know. And the main thing is the spontaneous resolution, role of congenital antibiotic prophylaxis. Is there a need for reimplantation? If so, why, when, and how? Has our present day treatment option improved the development of renal and its history? Will reimplantation of grade 5 reflux be a benefit to the patient? This is my biggest problem. Will grade 5, I always call grade 5 reflux as a benign form of malignant disease, because most of the children, even due to surgery, progress into renal failure subsequently. Next slide, please. Now, this is something that is coming up in a big way, and there are many, like my own colleague and student, Dr. Venkatesh Krishnamurthy, Ansari, all these people talk a lot on dysfunctional voiding. And remember, this dysfunctional voiding was spoken about even in 1961-62 by Hinman and later on Allen in 1974. And today, we are thinking that most of the problems that we have faced with VR is because of dysfunctional voiding. And even though the patient may not have a bladder bowel syndrome, they still can have a dysfunctional voiding. We have to understand in the management of VR. And without understanding this, both PUV and VR, the treatment that you adopt ultimately may be inefficient. Next slide, please. Next slide. Now, should pediatric urology become a subspecialty? Recently, thanks to our president and secretary, an attempt is being made to develop urology section in sections in urology, and thank God, pediatric urology has been also given a status of section of pediatric urology. But the question is, are we too late in forming the structure, pediatric urology subspecialty? I think we are a little bit too late, because we ourselves, in our interest in doing endourology, handed over pediatric urology to the pediatric surgeons, and to get it back from them is going to be very, very difficult. But at the same time, Shyam and myself, for long, tried to create an awareness of pediatric urology as subspecialty, but it fell on deaf ears for the administrators or the presidents and secretaries of various types. I'm not going to crib on it. At least we have started something now. we should continue. But the most important thing is, if you can start and earnestly have a certificate course for pediatric urology as early as possible, and in as many centers as possible, we will be able to get many people interested in pediatric urology, which we are not doing now. Next slide, please. Next slide. Finally, friends, I must thank my better half, late Professor Nalini Venugopal. She stood beside me, thick and thin, and given me ample leeway to progress in my chosen field. I dedicate this talk offering to her memory. Thank you very much. Thank you.
It gives me great pleasure to welcome Dr. Professor Chinnaswamy. Professor Chinnaswamy is a doyen of Indian urology and one of the senior most in the country. He did his MBBS and also was a professor of urology at the Madras Medical College of Chennai, and past president of India. Welcome, sir. Please share your thoughts.
Sorry, after such a brilliant talk by Venu, I have very little material to present to you. On a Teacher's Day, I just want to say that teaching urology has made a lot of difference with the advent of videos and TVs. Before that, they used to have open surgical procedures only were visible to all. Endourology procedures were in a peep show. Now, thanks to the modern development, it has become very easy for everyone to see through the video. Anyway, thank you very much for today's talk. Venu did a very good talk. Thank you.
Arun, move on to the next.
Ravi.
Sir, it's my proud privilege, and I'm humbled to be given this chance to introduce Professor N.P. Gupta, sir. As we all know him, he doesn't need an introduction to this audience, but as a customary, I would introduce few of the very few persons in our society who received the Padma Shri by Government of India, who received recognition from Government of India at a national level in the form of BC Roy Award. He has been the president of our USI Society, Urology Association of Asia, etc., and he was the former head of the department. So over to Gupta, sir. I'm honored to introduce you for this meeting. Thank you, sir.
Hello. Can you hear me?
Yes, sir. Yes, sir.
Thank you. I'd like to thank USI for giving me this opportunity to speak on TURP, how I do it. I'm going to share my 46 years experience of TURP, which is one of the most favorite operation for myself. Transurethral resection of prostate is the gold standard in surgical management of BPH. It has stood the test of time of 91 years, and it is the most commonly operation done by a urologist, and I will say it is bread and butter for the urologist. Now, it is a long journey where we have reached today. So, in 16th century, Ambrose Paré described the first transurethral operation of obstructed bladder neck outlet using curate. Bogini in 1807 described this endoscopic device. Nitsch in 1877 described the cystoscope, and Dr. Young has described the first cold cup prostate punch operation. In 1926, Max Stern described the first resectoscope. In 1931, Dr. Davis has described the cutting current diathermy machine, and this all has been combined together. And Dr. Joseph McCarthy, he described the first resectoscope technique of TURP. And Need Rasbit, these are the pioneers who have described the different techniques of doing section of the prostate. Iglesias describes this continuous suction irrigation, and this has changed the concept how we are doing today. Harold Hopkins have described the rod lens system. Then TUMT came. Later on, this concept of thick loop resection has come by Pearl Buter in 1993, and 2004 bipolar TURP has become very popular. And I still remember that since that time, my preferred operation is bipolar energy for resection of the prostate. If it is not available, I'll use the monopolar. And these are the new energy sources which has been used for treatment of the prostate. I want to show you this slide to understand that the anatomy of the benign enlargement of the prostate. Endoscopically, we see 3 lobes, the median lobe and the 2 lateral lobes. The most important thing, the most common complication of the TUR prostate is the bleeding. And to understand that, you should know how the blood supply to the prostate. These are the flux artery which enters at 9 and 11 and 2 o'clock position. And these are the branches of the artery. And then we have duodenous artery, which are supplying at the near the sphincter. And you can encounter all these vessels. I am going to show you my technique, how I do the TUR prostate later on. I consider the golden triangle of TURP, that we should identify the disease, about the size of the prostate, the anatomy of the prostate, and also it is very important to understand the patient, what kind of morbidities he's having, whether he has got a cardiovascular, neurological disorders, and it is very important the experience of the operator, and one should have very good instruments. So if you have all this together, then we can achieve good result of the TURP. Now it is very important to select out a case who needs TURP. It is not necessary then we should operate every case. And these are the standard indications which have been given in the test book, and this is what we are following nowadays. I consider this is more important to know the relative contraindication for TURP. Patients who have unstable cardiopulmonary status, those who have uncorrected bleeding disorders, and here we say don't do TURP. You can go for new energy sources, laser, or the new technologies which are coming, they can be used. Patients with myasthenia gravis, multiple sclerosis, Parkinson's disease with dysfunctional external sphincter, I think so these are the patients who may not be benefited by the TURP. So careful evaluation, urodynamic study is equally important. And now we have got this new concept has come, the hypotonic bladder or hypocontractile bladder or under activity detrusor. And the patients who have a large significant residual urine, more than 200 or 300 ml, then it is better to do a urodynamic evaluation before doing a surgical procedure. That will help us to know what kind of outcome is going to be, and patient can be counseled to say that he may not completely empty his bladder and need some additional treatment. Now I'll talk a little bit about the basic skills of the TURP. You all know that TURP chip is shaped like a boat. It should be as deep and broad as the loop and as long as travel the loop in and out of the prostate. So one has to learn this skill, how to resect the chip properly. And this slide shows the rhythm of the cutting. This is equally important. This comes by practice, not by just saying theoretically. And if you are too fast, then there will be more bleeding. If you are too slow, they may not cut properly. And how to make the boat shape. So this is important to learn. And this can be learned only in the operation theater. Bleeding, as I said, how to take control. A large vessel, the arterial, they can be controlled by coagulating at the tip, whereas the venous bleeding is difficult to control. However, you can compress the vein, not at the opening, but proximally, and there you can control the bleeding. Now there are different techniques of doing the TUR prostate, and they have been described. And this is the picture for the open adenectomy, and the aim of this surgery is to remove the enlarged adenoma, leaving the surgical capsule, as is shown here. Now these are the different techniques. One can resect one chip like that, and this was the originally described techniques. Then this is the Blandy's modification of the Nesbitt's technique, where we start with the median lobe and then we can resect the lateral lobes. It hardly make any difference which technique you want to do, but you have to be systematic. And one lobe at a time, otherwise you can get in confusion. And this is another technique of step-led pattern of resection. One by one lobe you can gradually resect from the surface to the depth. Now I will like to show you a video clip. This is the way how I am doing the bipolar resection of the prostate.
It's not coming, sir.
So maybe you need to click on the clip. It's not seen. It's click on that video, the triangular arrow, sir.
So first you deselect the box you have selected, na?
Yeah,
You
deselect. Yeah.
And then you come.
Now can you see?
No,
No,
sir.
Hmm?
No.
No. Okay. I'll stop here and I'll try to show you again.
Right, sir.
Can you see or no?
No. Yes, sir. No. Now yes.
You are off the presentation now.
So, sir, you can play it from the
Okay.
laptop directly. The clip you can play, sir.
No, where I have to leave, or how can I come out?
You're already out, sir. You're already out of the presentation. So if you open your clip and start sharing again, yes, now we can see, sir.
Hello, can you hear me?
Yes, sir. Yes, sir. We can hear you now.
This is the chips as we dissect, and you see with the bipolar, the charring and all that is much less. So post-operative care, normally we leave a three-way catheter. I put a small penile and right traction, saline irrigation for 6 hours or overnight. IV fluids till start in the evening, and oral fluids after 3-4 hours, and catheter removal as soon as the urine is clear. In my practice, mostly it is 48 hours or 72 hours at the most, and discharge after the catheter removal. Now, I like to highlight one thing, that 15 to 20% of the patients are not happy after the TURP, and they develop one or the other kind of complications. Therefore, it is very important to evaluate them. And these are the 3 major complications: urethral stricture, bladder neck contracture, and retreatment range is 3 to 14%. I'll show you some of these complications because I get the referred cases done by others also. And this is a bladder neck obstruction. The point I want to highlight that when you do endoscopy,
we are not seeing your presentation, sir. We are only seeing the video file. If you can switch back to the presentation, sir.
I don't know how.
You have to close this.
Yes, close this and
Close
come back
this
with
and then go to your presentation.
Okay. Main
sir,
part of the.
You can share the screen, sir, and with the presentation open as we do normally, that would bring the presentation back.
Can you see now?
Not
yet. Anyway, the presentation more or less is over. I want to highlight the that follow-up of these patients are equally important, and we should take care of. If they are not happy, proper workup has to be done, and according to the complications, they should be treated again. I like to thank you all for giving me this opportunity, and sorry for this mishap of presentation. Thank you very much.
Thank you, sir. Just one small comment. I'm always marveled by the way you adapted to the new techniques from old to new and adapted it into your practice. That gives a big lesson to us that that's how one has to evolve and yet adapt and continue to do new things. Thank you very much, sir, for leading us the way. So over to you, Arvind, for the next presentation.
It is my privilege and honor to introduce Professor Ganesh Gopalakrishnan today. Teachers of teachers, formerly professor and head of the department of the Christian Medical College, Vellore. He built the department to a preeminent position in the country and also abroad throughout the world. He established a training program that has stood the test of time and has helped countless urologists, including me. He has pioneered several procedures and also functional urology in the country. He's a BC Roy awardee and also the past president of the USI. He has inspired and continues to inspire many young urologists in the country, young and old. Thank you so much, sir. Over to you, sir.
Thank you very much, USI and the Indian School of Urology. I hope you can hear me. Can you hear me?
Yes, sir.
Yes, sir. Very good.
Yes, sir. Thank you. Once again, it's a privilege really to be here and for making an event of a day which in this country and throughout the world is recognized as Teachers' Day. we all continue to learn. So we are not actually teachers at this point, and every day is a learning experience. So we continue to learn from our peers, we continue to learn from our residents, we continue to learn from our patients. And so therefore, thank you very much for this opportunity again. I'm going to share with you some of the thoughts on how this particular condition of pelvic fracture urethral distraction defect is addressed. You all know that the Achilles heel of this particular condition and this particular defect is actually the posterior urethra and the dissection of the posterior urethra, to which I would allude to subsequently. But I think we need to make a distinction between a urethral stricture and a distraction defect. And today, from distraction defect, this has been now called a pelvic floor urethral injury rather than actually a distraction defect. So, you know, the terminology keeps changing, and we have to keep abreast of what is happening in the rest of the world, especially in terms of functional urology. The posterior urethral stricture is always never primary. It is a result of a failed surgical repair, and therefore we no longer call this primary event as a posterior urethral stricture. We call it as a distraction defect or an injury. In my mind, while there is a lot of hype about the MRI and the Coratem algorithm, etc., I still find that the RGU and MCU is still the mainstay as far as I'm concerned. An antegrade and retrograde cystoscopy in appropriate situations. In fact, I would do them at every case. And I really find no advantage of either the sonourethrogram, and I really allude to the MRI. Yes, it's a good theoretical lesson that you look at the MRI and you know how much is the defect, but only when you go in there do you realize how correct or how true the defect, the imaging was, and you just have to try to get the two ends to meet. And therefore, to reiterate once again, the first time in is the best time in as far as these conditions are concerned. And every redo produces a new set of issues and a new set of problems for the patient. So the principles of management of this particular condition is actually excision and primary anastomosis for trauma, a progressive perineal approach where all the callus is to be removed. And only if the perineal approach fails do we go for what is called the formal transpubic approach, which was enunciated by Keith Waterhouse. We all know this. I just want to highlight two particular procedures or steps of the operation that I personally perform. And one is the prostatic mobilization, which I find is necessary because the prostate is actually forced down posteriorly in the famous S bend, as Tony Mundy alludes to it. And I prefer to actually lift this off from the pelvic floor and also from the rectum. The rectum is actually a little far away because there's still so much of callus around this. And one is able to do this. And if you're able to do this, you get another 1.5 centimeters actually as far as urethral length is concerned. And this gives you a nice S bend as far as sort of a C shape as far as the urethra is concerned, finally with the end of it. In some situations, especially certain redo cases, I do resort to what's called the corporal plication. This is what we would call the reverse Nesbitt. This particular technique has recently been reported. I tried to report this in a couple of journals, but they refused to accept my article. But recently I found that in the Journal of Urology, this particular technique has been described by the people in Texas, and they use it not for trauma, but they use it for non-traumatic strictures, this corporal plication. So this is really something that is a fallback procedure or a step when you have difficulty in trying to get the two ends together. Supracrural routing, in my life, I've done it on three occasions only. And I think that most of the time you're able to get away with the above procedures. And only in the end, really, do you resort to a formal transpubic urethroplasty. So these are the two steps, and just to show you a cartoon diagram of the crural plication. This does not actually shorten the urethra. This is done on the fixed part of the corpora cavernosa. And when we did the study and reported it, only one patient in our series had a shortening of about 0.5 centimeters. And if you look at these patients after 6 months, you find that there is really no decrease in length of the functional length of the penis as measured from the base of the pubic symphysis to the tip of the penis. So this is a good step, I feel, in a situation which is very tight. Now, the thing is that in this particular slide, we see the prostate, and once you have divided the anterior urethra, you're now sitting on the looking straight at the pelvic floor, and you haven't yet identified the posterior urethra. So you use the Hay grooves or the cystoscope sometimes, and make sure that you actually get in the right place. I would like to emphasize that if you have any doubt, always keep the cystoscope on your tray ready. And the verumontanum is the most constant landmark in the posterior urethra. Every case you will have it, except when you have a double block situation where you have a block at the bladder neck also. This is very rare, but it can occur sometimes in some devastating injuries. But the prostate and the verumontanum are still there. They don't sort of fly away into midair. So it's still there. It's your business to look at it. And only if you're sure that you're in the verumontanum, that you know that you're in the right place when you do the final anastomosis. So once the Hay grooves is passed and you make an incision, you pass a Foley catheter. I like to do this simply because it gives me traction and it helps me to sort of get the planes between the prostate or between this area of the urethra and the lateral pelvic wall. Remember, the lateral pelvic wall and the bone is all compressed and is smashed down on the anterior surface laterally, depending on the type of the prostate, depending on the type of injury. And therefore, you do need to sort of separate all this out. I like to separate it out. I don't like to leave it at the end. And one of the things that I found in all the redos that I do, which have been failed urethroplasties, is that failure to go that extra mile where you need to dissect this out and get to that. Don't be sure that when you actually cut the Hay grooves or cut onto the Hay grooves that the urethral mucosa is sitting there. No, the urethral mucosa and the normal urethra is still behind. What you're cutting is the callus. So all that has to be shaved away till you get nice supple ends for your anastomosis. This part of the urethra is very vascular. So you don't have to worry about devascularization. You need to worry about devascularization of the anterior urethra in these redo cases. So I just want to share this video with you. This is the cystoscope which is coming out because the Hay grooves, we were a little unhappy with the Hay grooves. So we pass the cystoscope. Through the cystoscope, we pass a guide wire. The guide wire is retrieved through the suprapubic tract, and then a Foley catheter is passed into the posterior urethra. I didn't show you the step of the cystoscope, but since we had the suprapubic cystoscopy, we were sure that we were in the right place. So the Foley catheter is actually inflated now, and you exert some traction on it so that you have a steady pit. Now here the inferior pubectomy is going through. This particular case I did actually in Srinagar, and we had 4K transmission for this, and the clarity I'm told was amazing for the viewers. So this is the first time I'm actually operating on a 4K camera, and it was a little difficult to try to actually do it like you do laparoscopic surgery. So it takes a bit of experience and learning. So I use the Capillary gouge. It's a great instrument. You've got various sizes of the Capillary gouge. You got to chip it away. You need to do a bit of carpentry here. And really, sometimes you have to hack out a big bit of bone. Sometimes you have a small bit of bone. And you don't need to do the entire pubectomy. You just take out that which is sitting on top of the prostate and preventing you from actually having access. Once you get that, you can use a heavy scissors and cut out all the callus. And you find that quite a bit of this is still left behind. So you can either use a diathermy sometimes, or you can use a blade, a 15 blade or a 11 blade, whatever is your preferred choice. And here you can see that we have actually separated out a bit of the prostate. You can see you can see on the side here the charring effect of the diathermy. I love a bipolar, and this is a great instrument to use in terms of diathermy. So have a bipolar which is preferably hand controlled rather than foot controlled. Now, you see the Foley catheter is still inside, but the urethral mucosa is still not visible to me. I'm still chipping away at all the callus, and there's still quite a bit. There's still quite a bit of all that happening. So don't try to anastomose the anterior urethra now at this point. You are going to be in disaster. So it's all very variable. and you need to be sure that you've got good supple mucosa and good mobility of the prostate in this particular, in every case actually. If you need to do more pubectomy, you do more pubectomy. Now the urethra is being spatulated anteriorly so that we can expose the mucosa here clearly. And you still have to find, you still realize that there's a lot of tissue in front of that mucosa. So you got to cut it away. So to help you again, you put this Foley catheter in and then cut away at all the tissue that is in front of that mucosa. I would strongly recommend that you use a loop. I know there are many people with very good vision who don't use a loop. Many senior surgeons, I know very good friends of mine who don't use a loop, and I admire their vision. I've been used to a loop for many years and I can't do anything without a loop, including making a skin incision now. So this is where a bit of the prostate mobilization is done. You chip away at posteriorly so that you free the entire prostate. There is actually suddenly a plane which opens up. The initial dissection may be a little bit difficult. It's a little fibrotic, but if you use either an ophthalmic blade or even a 15 blade, you can just lift it up and you will see sometimes, or in fact, you see it most times, loose alveolar tissue, and you know that you are in the right place and the prostate just sort of lifts up. This operation is bloody. I mean, I know that we would like to have a hypotensive anesthesia in a situation like this. I've been to workshops in Sanjay's place where the anesthetist gave hypotensive anesthesia and the field was absolutely dry. I've been trying to convince a lot of people to do that, but surprisingly, it's not happening. But it's a great way to actually get the bleeding down in this pelvic floor. There's still some more to go. So, you know, it may seem all right to the naked eye, but, you know, when you use a loop, you need to be sure that you get a much better view when you use a loop. Now, one of the things that happens is on the surface of the prostate, you have the blood vessels, and therefore this bipolar is pretty useful for you when you actually coagulate those vessels. Just a little bit of more toileting to just make sure that the ends are supple. And once I'm happy with the ends, I always use everting sutures for the mucosa. So it stabilizes the mucosa and enables me to actually take the anastomotic sutures quite easily. I strongly believe that these sutures actually stabilize the mucosa and does not allow any flap or false passage creation in the final anastomosis, because once this is done nicely, then you can actually do the anastomosis. So, as they say in surgery, there are many ways to skin a cat, and there are many ways that this posterior urethra can be tackled. But I'd like to emphasize again that this is the Achilles heel of this operation. And if this part is not done well, then, you know, it's bound to fail. And failure doesn't happen late. Failure happens immediately after the catheter is removed. The patient tells you that his flow is not good, and then you can make it out that the flow is not good. I do this on both ends, on the distal end as well as the proximal end. And once you've done this, then you're ready for the anastomosis. These are parts of the dorsal vein of the penis, which were coming in the way in this particular patient. So we just ligated and divided it. It's got branches, usually two, vein stem and two branches. You divide it. So then the dorsal vein gets retracted, and you are able to get some more space in a place which is rather crowded. Sometimes when you do the crural separation, you might encounter yourself going into the corporal cavernous tissue simply because the pelvic bone has been smashed in a different way and there is distortion. So just to take care of the bleeding, you can anastomose you can suture up the albuginal tissue so that there is no further bleeding inside. I prefer to take all the sutures and tight, and then pass the catheter at the end, so that, that's how I've always been doing it, and I continue to practice that every day whenever I do a PFU-DD case. One of the reasons why I prefer to do it this way is that in case the catheter falls out in the ward, then the resident should be able to pass it on his own. This is a difficult operation to record with hands all over the place and your headlight coming in the way. So it's a great skill on the part of the recording team to have done this. And at the various workshops where we attend and we do these procedures, there's no doubt that the man behind getting us the good videos is actually the most important guy. I use 5-0 Vicar for the everting sutures, and for the anastomosis, I use 4-0 PDS or 5-0 PDS if it's a child. Now, the only difference I have as far as children are concerned is that I don't sort of divide the bulbospongiosis muscle. I take the entire urethra along with the bulbospongiosis muscle and then fix it back again to the side wall of the pelvis. The reason I do this is because the urethra in the child is very fragile, and I want to preserve as much of tissue around it as possible so that I don't devascularize the urethra. Now the anastomosis has been complete and we are doing a spongioplasty in this particular patient. The catheter goes through. So this is exactly the way we do it. And the salient points are cut back till the prostate is proximal and normal. And you must excise every bit of tissue till you see healthy urethra on both sides. And it's invariably always a prostatobulbar anastomosis in most of these cases. You're sitting just in front of the verumontanum. And in the redo cases, it's the vascularity of the distal segment that we are concerned about, because in the redos, dividing the urethra again and again leads in many situations to the dreaded complication of total bulbar necrosis. This sometimes, as I just told you, is a problem. If you use the Hay grooves with force, you can create a false passage, and therefore you must be sure, 100% certain, that when you pass that Hay grooves, that you are actually in the right place. If you have any doubt, as I showed you in the video, pass the cystoscope and be sure that you are seeing the verumontanum and then come through from the top end. So therefore, if you do the posterior dissection, you are able to get about 1 centimeter or 2, and you get a nice curved anastomosis, a more wider anastomosis. Of course, the disadvantage is that the neuromuscular bundle is in this plane. Most of these patients are actually either impotent or have some form of ED. But the younger the patient, the recovery is pretty good. It's the older patient who's got diabetes and atherosclerosis that the risk of impotence is greater. But I think it's important that you take a history in these patients when you do actually operate on them. The transpubic approach is managed, is the ultimate. You don't have to do this in every case. And the vast majority of cases, you were able to get through with all the steps enunciated. And it's usually for more complex strictures or where you have associated problems, but it leads to more morbidity, a formal transpubic approach. And this is how you would like to have a post-operative X-ray. This is one of the children I did in Kolkata and Neil Ratan Sarkar a couple of months ago. And this is the sort of result that we would all like to see in our patient at the end of the day, 3 months after an end-to-end anastomosis. So thank you very much to the USI, and thank you very much to everybody who's been listening in. And I have no words to express except my gratitude to all the people who have been in Vellore and who are in Vedanayakam, where I am currently working, and who help me every day in my journey in the urethra. Thank you very much.
Gopal.
Yes, good evening to my teachers and friends. More than Dr. Desai, sir, it is my privilege and honor to introduce him in front of all of you. Although today is Teachers' Day being celebrated in India, Dr. Desai is truly a global teacher, having students from every country across the globe where urology is practiced. Now, we have learned many things from him, but the one thing that I have learned from him is that when it comes to any urological technology, Dr. Desai has accepted it, understood it, and assimilated it, and finally mastered it. So whether it was the ESWL and endoscopy of the 70s and 80s to the laparoscopy and robotics of today, sir has truly mastered all the technology. So with great pleasure, I present to you Dr. Desai.
Thank you, Dr. Gopal. Can I share my screen?
Yes, sir, please do, sir.
Okay. All right. Thank you so much for the invitation. And I would like to pay my respect to Dr. Chinnaswamy, Dr. Venugopal, Dr. Sharad Bapat, and all my friends here. And it is a great pleasure to listen to Ganesh and Venugopal and Dr. Gupta. And I was asked to talk about starting a laparoscopic surgery. Well, that was my pleasure. It started actually in 1996. Actually, I had a severe pain in abdomen in epigastric and hypogastric region. We thought it was a peptic ulcer, and we were taking some antacid, and they did a gastroscopy, and nothing was there. One day there was a severe pain in the back, but I had an ultrasound, and I did my ultrasound, and I found there were gallstones. And then I heard that of course that need to be removed. Then there was a doctor in Bombay who was started doing the Dr. Ande, who was doing the laparoscopic, and that was a gasless laparoscopy. And that laparoscopy, so I went and did a laparoscopic cystectomy. And it really, I was out in 2 days' time and I was back to work in 3 days' time. I was very much impressed. So that's how I thought laparoscopy was a good way to start. So I said, why can't we use it in urology if it's used in for a cholecystectomy? So basically, till centuries, the open surgery was a gold standard because the size of the thing which we were doing were quite big, and it required we never thought that we require a small incision to remove it. We had to have a large incision, and you do a large incision, you are a good surgeon, and taking out a big stone like that. But still, the morbidity of the open surgery as well, the search for the alternative procedure that yielded a similar success rate and shorter hospital stay. New is not necessarily better. In our quest for the new technology, we must be very critical in our choice. Is it better? To treat the disease and the body is the science of medicine. To deal with mind and the anxiety of the fear of the patient is the art of medicine. And the history of urological laparoscopy is started quite a bit earlier. In 901, they did it in the dog. But what really mattered was Ralph Clement described the first radical nephrectomy in 1991. That was the turning point. And that's where the laparoscopy started in the urology field. And then came the radical prostatectomy, partial nephrectomy, donor nephrectomy, etc. At that time, Dr. Gill was in States, and he did a lap donor nephrectomy as a research project. And then when he went to Cleveland, he started doing a donor nephrectomy. And at that time, we started doing that renal transplant in 1980, and 70% of the donor were female, and then either mother, sister, or wife. And we were very unhappy giving them a big scar. Now, I already had an experience of the laparoscopy. So I talked to Dr. Gill and said, why can't you come and do donor nephrectomy in our place? And he came down. He was very, very friendly, and he came down and he did 2 laparoscopic donor nephrectomy to convince our nephrology team and the urology team that donor nephrectomy is quite safe in the transplant. And in 1997, this was first time in the country a laparoscopic donor nephrectomy was done by Dr. Inderjit Gill. It came into the news, and that was a great achievement. And then that era where we paradigm shift from the open to a laparoscopic surgery. Then we again invited him in 1998 for a Urological Society of India upper track endourology instruction course in Riyadh. And then he did a couple of laparoscopic procedure. One was the tuberculous kidney. And here was a Mihir who had just passed DNB, was watching. And then he decided to go and learn laparoscopy. He went to Cleveland, and Gill was very, very helpful. He was with Dr. Gill, and Gill and Dr. Mihir, both of them, they helped us to start our laparoscopic program at Riyadh. And then there was a paradigm shift from open to a laparoscopic surgery. Of course, that time we need to have a modulated theater, especially for the laparoscopy. We had to have the equipment which was needed. I won't go, this is now everybody knows about it. And then we installed that in our hospital. And then, of course, you need a team of people who are used to the laparoscopy. I myself learned the laparoscopy, and then all my staff and the resident and the doctors, they also learned it, and they were the teamwork, and it was a good setup and a good teamwork. It makes a difference. So then, if the size was a matter, this was a bilateral polycystic kidney, and a 46-year-old man undergoing a transplant. and we had to do it. We did a laparoscopic bilateral nephrectomy and removed both the kidney. So size was never a problem in laparoscopic surgery. The short-term cancer control, when you talk about laparoscopy and urological oncology, the short-term cancer control rate appears equivalent to open counterpart. Urologists are becoming increasingly skilled in minimally invasive technique in treating cancer, need to merge unique skill and perspective of endourologist and a urological oncologist. We were endourologists then. Already we have started doing the endourology, and now we will concentrating on laparoscopy. And the Leonard Gomel pronounced that I now pronounce you man and wife, the laparoscopy and urological oncology. And then we started a lap uro-oncology, mostly laparoscopic radical nephrectomy, nephrouretrectomy, simple nephrectomy also for a pyonephrosis or a non-functioning kidney, nephron-sparing surgery, laparoscopic partial nephrectomy, and radical prostatectomy. So if you go organ by organ and review the standard procedure, those of the cutting edge, where we transferred open to a laparoscopic urology surgery, and there were first the adrenal, and this is the large adrenal mass, which you can see that, and we could clear it out by laparoscopy. Otherwise, in the initial stage, anything which was more than 5 centimeter adrenal mass, you have to do an open. But here you can look at it, the big ones, we could do it by laparoscopy. And then, of course, the kidney, a large tumor in the kidney, we have done laparoscopically, or a thrombus, we extended indication, went to the renal vein thrombus, and then also IVC thrombus, which was just extending into the level 1 or 2. We did a laparoscopically. Then the nephrouretrectomy for a TCC, which was in the kidney, which was going right up to the down in the ureter. We did a nephrouretrectomy, and then either the new bladder later on, but that was not laparoscopically, that was robotically, but still we did this procedure. Then came the laparoscopic partial nephrectomy. One of the most challenging laparoscopic procedure, requires a considerable prior laparoscopic experience and facility with a freehand laparoscopic suturing. We were already started doing the open partial nephrectomy. And of course, we cannot forget the contribution by Dr. Gill, Mihir, Jihad Kauk, and all the team from the Cleveland who came. And of course, my colleague Snehal Patel, I miss him. And we were all there who on the resident and the staff, we all started the laparoscopy, and they were there, and they did more than 10-15 of surgery to show us all the procedure. Well, all steps for the partial nephrectomy, where the steps of the open surgery are duplicated. We were using intraoperative laparoscopic ultrasonography to localize the tumor. Then we hilar dissection. Initially, we used Satansky clamp. Then now we are using an individual bulldog clamp on artery and vein. Then tumor excision marked by the ultrasound, and then we excise it, and then repair it, repair by the urinary collecting system, and then the urography will be suture the defect, and then control it. And we have done quite a bit of a surgery there. And then, of course, radical prostatectomy nowadays is ultrasound has, of course, given us a lead in diagnosing the cancer much earlier. And then we've been doing the dissection, nerve-sparing approach, and removing division of the DVC, urethra, final separation, and then the anastomosis. All steps of the open surgery were done by a laparoscopic surgery without a problem. Now you look at it. We have done about 10,791 open surgery, while laparoscopy is 5,350. Well, robotic is an extension of the laparoscopic assisted robotic surgery, and we have done 1,794. But mostly you can see radical prostatectomy, 34 to 91 to 693. Then you take a partial nephrectomy, 59 to 18 to 350. You take Anderson pyeloplasty, it was 691. We had done open. Now we've done 409 and 226. We are done laparoscopically and robotically, respectively. Radical nephrectomy 289, 598 laparoscopically, and little less robotically because there is no more advantage. So where there is a reconstruction advantage, we do robotically, otherwise we do laparoscopically. Similarly, a recipient surgery mostly is done open surgery. 35 we have done robotically. And the donor nephrectomy, which is ever since then we learn, and now we have ever since 2001 we have not done a single open donor nephrectomy. All donor nephrectomy are done by laparoscopy, and some obese patient we have done a robotic surgery. Similarly, all other surgery which I have listed out here are converted from open to laparoscopy, and some of them are laparoscopic to robot. But the open surgery we still continue, like Ganesh showed, the urethroplasty or any recipient surgery. Mostly we do open surgery, and some of the difficult tumors we have done by open surgery. But if you see adrenalectomy, which we have done 805, and you can see that the open surgery after about 2003, we started doing laparoscopy, and then we did robotic surgery. And this is how we are done. If you see the graph, the open surgery after 2003, it is dropped down, and the laparoscopy and the robotic has come up. Similarly, in a kidney transplant, in kidney surgery, except the transplant, the number converted from open to a laparoscopy and then robotic surgery. Again, the graph shows, you can see that the open surgery is dropping down and the laparoscopic surgery has increased. Laparoscopic surgery is also a cost effective compared to the robotic surgery. And then it is, and the result wise, it is also a comparable to the open surgery. Ureter, mostly we do endourology, and some of them ureter we do a laparoscopic and robotically, our reconstruction especially. But mostly ureter surgery is endourology for the stone. The bladder cancer is the most common condition, 999, and we have done combination major open the conduit and the new bladder we do or conduit we do open surgery, and some of them we are doing robotically now, and so that's how we are converting open surgery to laparoscopic and robotic surgery. Prostate, if you take, is the best example that we never started. We started very low in open surgery, but when we started, we went by laparoscopy and then by robotic surgery. And other surgery, if you see, are again where there is no advantage of doing a laparoscopy or a robot. We have done open surgery. But what is most important thing which we started was training the new generation. And here is a dry lab where they do the work on a lab simulator, and then they do on the wet lab where they do it on a porcine model, and then we have a time-to-time courses where they do it. Again, a single port laparoscopic surgery, we have done it. We do the teaching and training people. We show them the live surgery, and then so laparoscopy in 2022. If open surgery is the gold standard, whatever you do by open surgery, laparoscopic does it better, because we do believe every life deserves world-class care. So my multiport and then extension laparoscopic surgery stands on the shoulder of the open surgical excellence, and the robotic surgery stands on the shoulder of the open and the laparoscopic surgery. And finally, where were we? Where are we? And where can we be? I think this is the thing. It is always progressive. In my 45 years of practice, I have seen that we've been progressing from open surgery to minimal invasive surgery, endourology, laparoscopy, robotic surgery. And now that the technology is improving in every field, even in TURP is going out, and a robotic TURP is being done. And in every surgery, the minimal invasive surgery is come. There are people who make things happen. like Dr. Gill. There are people who watch what happens, and there are people who wonders what happened. What do you want to be? That's what I tell my students. Be the man to make the things happen. Be the creator, not the creature of the circumstances. The reward of the medicine is the honor and the privilege of caring for the patient. We have collected a treasure of almost 2 lakhs patients since the inception of the hospital till January 2022. We look forward to treating more patients, spreading the knowledge and marching towards providing the right of the health globally. And all this is possible is because of the different teachers. Some of the teachers stand tall, but then other teachers, they are there, debate is there, discussion is there, and that is helpful. So in conclusion, light looks bright at the end of the laparoscope. Thank you very much for giving this opportunity and sharing the my experience. And it has been a fantastic journey for me in last 45 years, where I have learned quite a bit of a new technology. And I do believe technology does save the life. And I think as a teacher is our job. And I mean, I'm very, very proud of the people like Ganesh, who's been doing the workshop all over the place. The Sanjay, my friend, Kulkarni, he has been teaching, not here, but all over the place. And we also enjoy teaching the students. And I'm very proud of my students, because some of the students have done much more than what we are doing. So thank you very much for this opportunity on this Teachers' Day. I feel very enjoyed that we have spent a good day. Thank you.
Thank you very much, sir. Truly, you are a master of technology. I hand it over to Dr. Arun Chawla.
Samir? Yes, sir. Good evening, sir. Good evening, everyone. It's a very good evening to all my esteemed teacher present over here. And I feel proud and privileged to introduce Professor Sanjay Kulkarni, where the name is the identity. And we all know what is his contribution towards the reconstructive urethral surgery and stitcher urethra. We welcome you, sir. And I feel it's very wrong to introduce Professor Kulkarni in detail. And over to you, sir. Kulkarni, sir, please. Hello.
You have to unmute. Sanjay, unmute.
Sir, unmute yourself, please.
All right.
Yeah.
Thank you very much, USI, Dr. Arun Chawla, Dr. Keshav, Dr. Sabnis, for arranging this program, fantastic program today on Teachers' Day, and following my guru, all gurus, especially Professor Chinnaswamy, Venugopal sir, Ganesh, N.P. Gupta sir, and Mahesh Desai. Is not easy for me to follow their footsteps. I'm going to speak about only urethroplasty. So I want to mention 2 of my gurus, Richard Turnavarik, who is considered father of urethroplasty. I was fortunate to be his first assistant for about a year at the Institute of Urology in 1986. And it was Dr. Guido Barbagli who asked me, Sanjay, what is your interest? I said, laparoscopy and urethroplasty. He said, forget about laparoscopy and concentrate on urethra. It was not easy for me to do that, but I could do that. I always want to tell my friends that Roger Federer, Sachin Tendulkar, they're the best players in the world, but they still need a mentor. So everybody needs a mentor to guide you through your career, and Guido Barbagli is my mentor. I want to show this photograph. This is a new hospital coming up, will be inaugurated soon. And it is among the top 3 urethroplasty institutes in the world. We perform about 500 urethroplasties. So that's considered as the highest number of urethroplasty in a center in the world. Tony Mandi, my friend, suggested that controlled clinical trials are unusual in surgery, rare in urology, and almost non-existent as far as the management of urethral stricture is concerned. What data there comes largely from so-called expert opinion, and the quality of the data is variable. So there are no controlled clinical trials. We published this endoscopy classification of urethral stricture some time ago. Normal bulbourethra is 30 French. If you can pass a 16 French cystoscope, it's 16 or 17 French. If you can pass a ureteroscope, then it's, sorry. If you can pass a ureteroscope, then it's 7 French. If you can pass a guide wire, it's 3 French, and 0 French is obliterative stricture. Joe Smith in 1960 suggested that unless the urethra goes down from 30 to 10, the patient will have no symptoms. So this is very important for us to understand what size of catheter we are looking at. I always inject methylene blue into the urethra, and it stains the strictured portion. And one must make sure that one dissects at least 2 centimeters on either side of the visible margin of the urethra. So apart from routine management like DVIU, dilatation, self-cath, the urethral stricture today is divided into 2 groups. Trauma, we transect for bulbar and for posterior urethra. Ganesh Gopalakrishnan has showed you a nice video. For non-traumatic bulbar or penile strictures, we want to augment whenever there is a lumen. When there is no lumen, we want to substitute the urethra. So this is an anastomotic urethroplasty. All of us are familiar with it. We now reserve this only for bulbourethral trauma. There are many papers published about sexual dysfunction, which could be as high as 25% in patients where there is no history of trauma. And we rarely ask this question to the patient, is your glans cold? Because glans is a part of corpora spongiosa. Now, coming back to evolution of augmentation or patch urethroplasty, Jack McAninch in 1996 presented his ventral onlay technique. The same year, Barbagli presented the dorsal onlay technique. These are onlay techniques. Now, Hari Asopa, who published 2 important papers, one is about hypospadias and second is about urethra. In 2001, he suggested this dorsal inlay technique where he made a ventral incision, dorsal incision, and inserted the graft in the midline. And we published this one-side dissection in 2009. So there are 4 techniques. Now, how do I decide whether to go dorsally or ventrally? So I make a perineal incision. This I'm talking about bulbourethral strictures. You can see the dissected bulbospongy muscle. Then I pass a Nelaton's catheter or a dilator, 16 dilator. If the dilator stops distal to the muscle, mid-bulbar onwards, I'm going to do a dorsal onlay buccal mucosa. If it goes deep inside, I'm going to do ventral onlay. Why? Once I incise the muscle, you can see at the base, bulb like a flower, it is wider by 2.5 centimeter. And here I can insert the graft ventrally. If I go mid-bulbar onwards, you can see the whole width of the urethra, including spongy tissue, is only 1 centimeter. And if I introduce here 1.5 centimeter wide buccal mucosa is going to fold inside. So mid-bulbar onwards, I'm going to insert the graft dorsally. Another saying is, I say that whenever in doubt, always incise the urethra dorsally and distally. So this is Jack McAninch, ventral buccal mucosa. This patient has a long post-TURP stricture. You can see the open bladder neck. We open the urethra ventrally. What happens is the sphincter mechanism, we do not want to disturb. The bladder neck is gone. So I open the urethra. We work inside the urethra, incise only the mucosa and insert a graft ventrally. So we in our unit reserve this ventral onlay buccal mucosa for obese patients, for post-TURP patients, and in a young sexually active male. So if I don't go dorsally, there is less chance of erectile dysfunction. So
connectivity issue maybe. Dominic?
Yes, sir.
Probably we lost the connection, sir.
Yeah, just a few seconds we'll wait. I'll call him also. I'll call him also. He's joining with a few seconds. Yeah, some connectivity issue. We'll just hold on. Yeah, he's there.
I'm sorry, my computer just shut off.
No issues, sir. Please go ahead, sir.
But your slides were visible.
Slides are visible now?
No, now
No, sir.
again.
Yeah, okay,
have to
just a
share
moment.
again.
Please reshare.
Yeah, okay.
You share your slides.
Yeah, just a moment. The computer just went off completely. Can you see the slides now?
Yeah.
Yes, sir.
Yeah, I'm sorry. So that's Barbagli technique, where we do circumferential mobilization of the urethra, open the urethra dorsally, and then insert the graft dorsally. Now this we reserve for complex near obliterative urethral strictures so that we can take care of the obliterative segment. So this one-side dissection is used for penile urethra. In this patient on the left, you can see circumcision incision. We deglue the penis, mobilize urethra on one side, and then insert the graft dorsally, and we can close. This looks like a circumcised patient. On the right, you can see a vertical incision in the midline, and you can again do one-side dissection. So two types of incision of penile urethra, circumferential or vertical. Now, whenever we have a bulbar urethral stricture, we make a perineal incision, go on one side, incise only the bulbocavernosus part, open the urethra dorsally, and then we insert the graft dorsally. Here, the advantage compared to Guido Barbagli's circumferential mobilization is that the urethra stays where it should be, and it is not lifted completely, and we maintain the neurovascular supply on one side. All of us know the problems of two-stage pan-urethral stricture, and everybody is familiar with the technique that we published, one-side dissection dorsal only after penile invagination. I learned this invagination technique long time ago in England when my boss used to do cysto-urethroprostatectomy for multifocal TCC, Michael Heel in Crewe. I'm happy to tell you now that this Kulkarni technique is now published in the Hinman's Atlas of Urology, and happy to tell you. Now, recently what happened, we are getting more and more patients who are non-BXO patients. So, and then some patients are cardiac cases where the anesthetists do not want to give general anesthesia. So under spinal, we make a perineal incision, and then we harvest a preputial free graft. Now this is a outer circumcision incision, inner circumcision incision, and we have a cylinder of the preputial skin coming out. So we are leaving the dartos behind. This little delicate dissection similar to a flap which we create, but there is no flap here. We are just pulling the skin off. So you can see the blood supply, which is left with the patient with the tunica dartos. And then once the inner and outer circumcision incisions are joined, we have a sleeve of the skin, which we roll over a syringe. And then we have 1.5 centimeter wide and maybe 12 or 14 centimeter long spiral free preputial graft. I presented this video in EAU, in AUA this year, and again in USANS. And then whenever we were using 2 buccal mucosa graft, now we had some problems with the junctional strictures. Now here what happens, this is a long free graft, but the junctional strictures have gone. And in those patients where there is no lichen sclerosus, this is treatment of choice today. Now there are some patients where we have used it for lichen sclerosus also, because there is no other way you could do surgery in this patient. The patient does not want to do any further oral graft harvesting. Now coming back to non-transection bulbar urethroplasty, which was popularized by Professor Mandi, here we make a circumferential mobilization of the bulbar urethra. We open it longitudinally, proximally, and close it transversely. Now, if the stricture is tight, then we do mucosal anastomosis and then insert the graft dorsally. So Pankaj Joshi, my associate, introduced this Joshi step recently, which has been published in the literature. On the left, you can see the narrow segment here. And without incising or excising the mucosa, he's just going to pull the dilated portion from below up and is going to do mucosal anastomosis. We call it the Joshi step. Whenever the stricture, the near obliterative portion of the urethral stricture is longer, more than 5 millimeter, we have double face buccal mucosa graft. But if I do it for very long double buccal mucosa graft, the success rate is not really good. Then we use graft plus flap. I just want to tell my fellows that the Indian urologists today are the world leaders in urethroplasty. We have traveled to more than 50 countries, me and Pankaj together, and we have taught urologists around the world how to perform urethroplasty. And I'm proud to say we are the world leaders. Thank you very much.
Thank you, sir. We are really delighted to have you here. And over to you, Chawla, sir.
Sharma, over to you.
Good evening, respected teachers. It's a pleasure and privilege for me to introduce Dr. Nitin Kekre sir as our next speaker. Of course, he needs no introduction. He has more than 200 publications. His articles have been cited by more than 10,000 times in various journals. And he is a teacher and surgeon par excellence. In one word, if I have to describe, his name exemplifies his entire career. The word Nitin comes from Niti, which is morality, and he is the knowledge. The word Nitin means knowledge, the torchbearer of morality, and his conduct as a teacher, as a guide, philosopher, and an examiner exemplifies his name. Over to you, sir.
Can you see my slides?
Not yet, sir.
No, sir.
All right. I already started sharing. I don't know what is the problem.
Please unshare and go back again to share, sir.
I don't know what's happening, Arun. I'm getting your face in front of me.
Navneet.
Navneet, can you help?
Sir,
Now,
if the
as
file is
presentation, we can put it.
or you can just share with me, sir. I will present it. Sir.
Nitin sir, just log out and log in again.
No, I'm having this. Is it visible?
Yeah, it's coming, sir. It's coming.
Thank you. So thank you very much for your kind introduction. I am extremely grateful to Urological Society of India, Indian School of Urology, especially the chairman, Dr. Arun Chawla and Dr. Keshav Murthy, for giving me this opportunity to share the dais today with such stalwarts. Before I actually start, I would like to pay tribute. It's a Teacher's Day to all my gurus, especially Dr. Ganesh Gopalakrishnan, from whom I learned ABC of Urology. Professor Venugopal, whose teaching and whose passion for urology teaching has no parallels. Dr. Mahesh Desai, whom I really consider as a Jagat Guru in the field of endourology in the world. And Professor N.P. Gupta, who has trained many stalwarts and was shining in the field of urology all over the world. And last not the least, Sanjay, who I can now be considered as a stricture guru. And before I proceed, I think we at the same time must pay respects on today's day to all those patients who we have used, we have treated them, and each of them has taught us lessons. So I think it's the right thing, right time to also remember them and pay our respects. Now, I was very pleasantly surprised that I was asked to speak on TURBT. It is an operation which is rarely discussed in the urology forums, very rare. If you actually go and look at all the conference workshops, this one operation which very rarely figures. It was it's a very old operation. It was described in 1962 by Professor Sweeney at Newcastle. And I have now called it Theranos, the infamous Theranos company, I'm sure you're all aware of, because it is both. It is therapeutic as well as diagnostic. And if in today's language we have to describe TURBT, we would say it's a focal, targeted, personalized, single port, natural orifice, repeatable procedure. Now, this is a fundamental procedure on which, or rather a foundation on which the treatment of bladder cancer gets best, because it is not only diagnostic, it has its staging, and of course, its role in therapy, that is treatment, I think is huge, especially in non-muscle invasive bladder cancer. So the issue is, why is this that this operation is not discussed? Is it because I think people think it's an easy operation? Most of the time a trainee is given TURBT maybe as a first operation. But if you ask me personally, this is one operation which I consider both teaching and learning. I for myself found it very difficult to learn, and it's a deceptive operation. It makes you feel, oh, you can do it. But to do a good TURBT requires a lot of practice, a lot of coaching, and then only one can probably could say that he will be able to perform a good oncologically best result-oriented TURBT. This is one paper which is from Los Angeles where they looked at the value of TURBT and found that in almost like more than 50% of the specimen did not have a muscle. They also found that the urologist's ability to discern between a non-muscle invasive bladder cancer, especially TA versus T1, is remarkably poor. So it again boils down to the point that you are completely dependent upon a good quality TURBT to decide the course of the treatment. So the objective, of course, as we all know, that we not only have to remove all the tumors from the bladder, but basically we have to provide the pathology. The pathology is a specimen which they can evaluate. If you are going to burn the specimen, they won't be able to see anything. So not only that, you have to provide them a good quality specimen, and as you expect them to report to you the depth of invasion, the muscle invasion, you need to provide them tissues separately and adequately so that they can provide you with a good diagnosis. Now look at these results. How many times the patients have residual tumors? Roughly, you can say 1/3. About 30 to 40% of the time, that the patients who undergo TURBT, especially for a T1 or a TA disease, they have significant amount of residual tumors. So if you obviously far more common than one would usually like to think. Similarly, way back, Harry Hare showed us what is the role of restaging, especially in T1. He showed that there is always a residual tumor. There is an upstaging significant if you go and resect, re-resect, and also showed the prognostic value of a good TURBT. If there was no residual disease in the specimen, there was a muscle involved already in the specimen, the disease progression was at the lowest, while in comparison, 82% had a muscle invasion if they had a residual T1 disease on a repeat resection. So from then on, the practice of re-TURBT in T1 came, and again, it was basically dependent on the poor quality of resections people were doing at that time. We in Vellore get a lot of patients from outside, and we did a very interesting thing because we usually ask patients when they come for further management to get the block and the slide so that we can avoid a repeat or a TURBT. But unfortunately, to our surprise, a large number of slides and the blocks are of very poor quality. Almost 70% patients had no muscle in the specimen, so most of them we had to repeat. Again, boiling to the same point that we have a long way to go before we can say that we are training people adequately in performing a good quality TURBT. The common question which always comes to our mind as a teacher or as a student, that how many TURBTs I need to do before I could consider myself that I'm good at it. There's one study which tried to look at it, and the number is surprisingly high. It says that minimum of 100 cases. And they say your outcomes get better after 170. Now, such volumes are difficult in our setup. How often one can give a trainee or anybody such high quality numbers? And we were no exceptions. Way back in 1984, when I got trained in Vellore, we didn't have video in urology. The senior person will resect inside the bladder. We are only watching the light. We had an articulated arm sometimes. We'll put onto the receptoscope, but very difficult to see. It was not, you couldn't see anything inside. And majority of the time, the resecting surgeon will also find the weight of the articulating arm painful and you say, please take it out. So learning endourology was an extremely difficult job. We could do independently kidney transplant, donor nephrectomies, radical cystectomies, but a thought of doing a TUR, large tumor bladder or a large prostate would give you sleepless nights. So I was lucky that because of my guru, again, Dr. Ganesh Gopalakrishnan, I had an opportunity to go to Freeman Hospital in Newcastle upon Tyne, where I met this man with Mr. Reg Hall. He was a uro-oncologist at Newcastle upon Tyne and one of the best surgeons I have ever seen. He was excellent in open surgery. He was unbelievably skilled in endourology. So he was the person who actually taught us, me and my colleagues in Vellore, most of us learned our skills of endourology, especially more so in a bladder tumor from him. The reason was that he was involved that time as a EORTC person into multiple bladder cancer trial. He was having a trial with Harry Hare on radical TURBT, where we used to go and resect the bladder tumor entirely to the perivesical fat outside as a part of multimodality treatment to conserve the bladder. And he also was involved into multiple BCG and other trials. So each list of his will have 15 or 16 bladder tumor cases. And there where I had the opportunity to actually get exposed to the volume and also to learn the fine nuances. He is an extremely well-read, very well, his care about cancer is absolutely wonderful. His principle, which he taught that time, still hold good. His opposition to PSA screening, he was against total androgen blockade, and all those concepts today have been proven to be absolutely correct. So it was a great to work with him. And even today, after retirement, he's still working with cancer. He is the person who taught me cancer is not a disease only. It affects so many things. It affects the people, his family. And even after retirement today, he's working hard in improving the lives of the cancer. And that's a learning message for us, that do not treat diseases, but learn to treat patient and his family when it especially comes to cancer. Now, so when I came back from Freeman, I actually kind of was very passionate about teaching endourology because that was not was difficult. By the time, luckily, we also had video endoscopy camera where in 94. And so we decided, all of us decided that now we should train our people better. And this is a proof which we have with the paper which is published in Indian Journal of Urology, where it shows that in our study, majority of the specimens had muscle in the specimen. The quality of resection of our, and majority of these cases are done by the trainees under supervision. So that was a great thing of satisfaction. And even I can say with confidence today that many of our trainees who have gone from below do better job than probably which I can do. So what is the difference? What is the difference between a TURP? All of us usually get to do TURPs more common, as a more common operation used to happen. And there where the problem begins. Prostate is a fixed structure, while the bladder is not. The bladder keeps going up and down with respiration. The bladder keeps moving with filling and getting distended. And it is not a straightforward organ. It has a spherical contour. And so unless we learn how to resect it properly, you will not do a good job. So it is very, very important to recognize this difference between the prostate and the bladder. If you are going to resect the bladder tumor, the way you resect prostate, you will never be able to do it well. The reason is very simple, as I said, that you have to consider all these issues of the bladder, and more so also its proximity to the obturator nerve, which sometimes make life difficult because of the obturator jerk. What is there in the instrumentation? Anything different? I think you must have a good quality cautery. I think that's an important thing. If you have a poor quality diathermy machine, I think doing a good endourological procedure is difficult. It is equally important that apart from the so-called 90-degree angle loop, which we use for TURBT, we need to get used to angle loops. There are two angle loops are usually available. One is a 180-degree, which is a straight loop, which is very useful to be used in a sweeping movement on the posterior bladder wall or near the dome, or the angle loop, which is angled at a 45-degree. So these two loops are absolutely essential for dissecting bladder tumor at locations which are not near the bladder neck or almost near to the bladder neck in the anterior bladder wall. Most of the other bladders will require some kind of a modification of the technique, and these loops make your life very easy. You can use unipolar or bipolar, that I'll come to that later. It is extremely important. And at that time, at least it was very important because the flexible cystoscopy was just coming in, that you had to do a 70-degree telescope at the beginning and at the end of the resection. So there were 25, 35 tumors in the bladder. You resected them, you used the 70-degree so that you don't miss any tumor. Of course, today, majority of us do flexi cystoscopy. So if the flexi cystoscopy has been done, the chances of you missing a tumor near the bladder neck or the lip of or the blind areas to the 30-degree are very less. But it is very, very important that if you don't have a flexi, please have a 70-degree telescope and develop a discipline of doing it after resection as well as before resection. And of course, you should be comfortable sitting to do this procedure, and the video endoscopy makes you do that very easily. So the main objective, as I stated before, is not only that we remove the entire tumors which are there in the bladder, especially more so in the non-invasive cases, but to provide the pathologist a specimen which is devoid of artifacts so that they can give you a very good pathological diagnosis, which actually forms the foundation of further treatment, whether it is you are going to go a BCG or you are going to do early cystectomy. Obviously, this is something more important in TA and T1 cases. So, of course, pre-assessment of this patient is extremely important to basically decide. Today, with the cross-sectional imaging available, majority of the time we know that the tumors are invasive. So in such cases, there is no need to do an extensive resection. But when that thing is not clear, or the disease may be TA or T1, you need to resect all the tumor. You need to decide at the beginning whether the tumor which is available in the bladder is large, how many, and can you resect it in one go. There is absolutely no harm if you decide that I can't resect it in one go without increasing the morbidity, to stage the resection. The idea is to make sure that the resection is staged and everything is done properly. So that is the way the preoperative and the value of a cross-sectional imaging becomes important. The surgical technique, what is the difference? As I said, the number one, the difference is between the TURP and the TURBT is that TURP is done by the movement of the working element, while majority of the TURBTs, you should learn to move the resectoscope, not the loop. Learn to move the resectoscope out along the contour of the tumor so that you can remove the large chunk of tissue without actually damaging anything. Another important step is that you keep the loop away from the bladder wall. One of the mistakes which the trainees do is to put the loop like you put on the prostate or the bladder wall and put the current. Immediately the current goes, stimulates, and you have a jerk and you perforate. So it is important to start the current away from the bladder wall, do a kind of a movement in the air of what direction you are going to follow, and then move the entire resectoscope. Using of whether angle loop is required or on a posterior wall, a sweeping move of the working element. There is no need to move the working element, and it makes your life very easy. This particular video clip which I am showing is by a trainee. So who have been taught well, and I think he's done an excellent job. And as you could appreciate that he's not moving the working element, but moving the entire resectoscope. So these are the few important. Similarly, on the anterior bladder wall, you need to learn to put a suprapubic compression so that you can bring the tumor into your view, have a gentle compression, and one need to resect, learn to resect with the one hand so that you can control the depth and remove all the tumors from those difficult positions. Lateral wall tumors are always a problem, as we know, because of the proximity to the obturator work. I think we prefer general anesthesia with muscle relaxant. But if a patient cannot have that, I think an obturator nerve block with a spinal anesthesia is a good option. But it's very, very important to be cognizant of the fact that the tumors on the lateral wall will have this problem. And despite of your best precautions, sometimes you will perforate. Now, perforations are nothing to worry about. They can happen. Majority of the time, they don't cause any serious problem. And the risk of tumor implantation, I think, is more a hype than reality. If all this doesn't work, then you may have to use an intermittent or a static temperature or current to remove the tumor so that you don't damage the bladder because of the obturator jerk. Is the bipolar tumor? It has been suggested in the literature that the bipolar TURBT offers advantage over monopolar because of that it produces less obturator jerk. Unfortunately, we didn't find this, and in our own paper, which I'll show you later, that we did not find that advantage with the bipolar. Certain sexual situations, especially when the tumor is around the orifice, I always tell my students that you resect the tumor irrespective of the ureteric orifice. It doesn't matter. The job is to remove the tumor. Majority of the time the ureteric orifice will not get obstructed. If patient gets symptomatic, you should do an immediate ultrasound. If you use too much of a cautery, I think it will be safer to use a stent. But otherwise, stenting is usually not required. And the reported literature rate is 12%, which is, in my opinion, very high. It is quite low. So there is no need to worry about ureteric orifice. Same thing about diverticulum. Can the diverticulum tumor be resected? Yes, they can be. If you want to resect a diverticular tumor, you need to enlarge the opening of the diverticulum by gentle resection. And then you can, using an angle loop, you can clear the tumor. So both the diverticulum and ureteric orifices tumors can be resected with ease. Sometimes, despite of the best attempts, some tumors are extremely difficult to reach. You know, you're trying your level best, you put your head down, Trendenberg, everything, but sometimes the tumors are difficult. The easiest technique that time or trick that time is to reduce the volume in the bladder as much as possible. Just make sure that the two walls are slightly apart, and then you will be able to see them and get the tumor in view, whether suprapubic compression on the anterior abdominal wall or near the bladder neck, and you can safely resect that tumor as well. Complications, as I said, bladder perforation is the most common one. And one of the commonest reaction which happens of a trainee or anybody when the perforation occurs is a shock. You want to stop the resection and get out. This is what I was taught by Mr. Hall, saying, what is the problem? What is the guarantee the next time you will not have the same thing? So he said the problem happens in this because there is a flap wall. and the water keeps going out but doesn't come back. So he said, you know, what you need to do, you get on with the other tumors, come back, saucerize that resected, make sure that the fluid gets sucked, and the patient will never have any problem. And we have followed this policy today, and I can tell you that we never had to put any drain in a patient because of extraperitoneal bladder perforation. So basically, nothing to worry about. You might have to keep a catheter for a day or two extra, and all these patients recover without a problem, and there is hardly any risk, frankly, of any tumor implantation. So this is the paper which I was talking about, where we compare the bipolar TURBT with the monopolar, which was published in Journal of Urology. And what we found was that we did not find any significant difference related to obturator jerk, bladder perforation, or hemostasis. But only difference was the quality of the resected specimen. The pathologists were very happy with the specimen received from the bipolar energy because of the less cautery artifacts. So I think from that point of view, it makes sense to use bipolar technology for bladder tumor resections. En bloc resection is getting common today, but it has limitations. It cannot be done for larger tumors because it's extremely difficult to retrieve them. But yeah, it has an advantage that will probably reduce the so-called tumor implantation, for which we put intravesical mitomycin. So what should we do? I mean, when it comes to training, this, as I said, this is one of the most common and difficult operations. And I think the departments should audit and should invest into the training on resecting of bladder tumors. A checklist is a good idea, which has been suggested. I think it will help you to standardize the procedure. Your trainees will learn to do it in a standard fashion. They will learn to report in the standard fashion. And if you follow, as you say, 1, 2, 3, 4, 5, in every case of a bladder tumor, it will improve the quality of TURBT, and ultimately will improve the quality and the survival in bladder cancer patient. So this is what I have already told you about en bloc resection. So what about the newer technologies? I think they're very good. If you have a blue light, you definitely will be able to reduce the recurrence rate, the true recurrence rate at least. What I was taught by Mr. Hall was that after resetting, especially non-invasive bladder cancers, we will take a rolling ball and a cutting current and roll it all around the mucosa. The normal mucosa will be fulgurated, and that basically was his attempt to reduce the true recurrence rate, the recurrence rate near the site of the original tumor. So that is one thing. It is very important to develop a standard formatting or standard way of reporting the bladder tumors. You can follow whichever way you want. And as I said, flexible cystoscopy is a must. And if you don't have it, please go ahead and use a 70-degree so that the quality of resection will improve. Once again, I take this opportunity to thank the Urological Society of India for this opportunity. Thank you very much.
Thank you, sir. Thank you, sir, for an enlightening talk on TURBT. And definitely it has highlighted every aspect which a trainee and even a urologist with significant experience has difficulties. Thank you so much, sir. Over to Arun, sir.
Sorry, I escaped for this.
Dr. Keshav, would you like to place any comments before I conclude, sir?
Can I stop the video? No, you can continue. I just said hello and go.
Dr. Keshav?
I came for this.
Unmute yourself. Keshav, you have to unmute.
On behalf of the Urological Society of India, let me thank all the speakers today. We are humbled by their words of wisdom. There are loads of experience which were put in 10-15 minutes. And this was what Professor H.S. was telling, that you listen to his rounds, it would be reading chapters together. So that is what we learned today in these 2 hours. It was a fantastic session. And I must congratulate Dr. Arun Chawla for conceiving this idea and executing it. Thank you. Over to Arun.
Dr. Sabnis, for any comments, sir?
Yeah, so thank you very much. I think this was one of the best session of this year. These are the masters who were passionate about one particular thing. They mastered it, they perfected it, they have mentored it, and they have passed on to so many generations of urologists over the years. And listening to them of their passion and of their liking subject was a treat to listen and treat to watch. I think this was well conceived and well executed by Dr. Chawla. And I must tell, that we have so many teachers in USI, and they are the just glimpses of what the plethora of teachers we have. And I must also pay respect to all those who are watching, the teachers and those who are not at present on this platform. And we also admire and appreciate their services and their struggle for bringing to USI and urology in India to what we are experiencing today. So thank you very much. Dr. Chawla, please take over.
On behalf of Indian School of Urology, let me thank my board members who have been with me in preparing this program and execution of this program. And to place the concluding remarks, let me say that a teacher takes a hand, opens a mind, and touches a heart. Teachers are those game changers who are real motivating factors behind our success. They encourage, mentor, and guide us to reach the skies fearlessly and passionately. They care and believe in us when we lack in confidence and are unsure of our own capabilities. Today, we admire and thank from our hearts all the legends, doyens, and role models for all the knowledge they share, and adore them for their ability to touch our hearts by their constant guidance, leadership, and directions. At the same time, many thanks and happy Teachers' Day to other teachers, teacher of teachers, who have not been here as a part of this program or on this virtual program, but they stay in our hearts. Lastly, I end by paying tribute to all the teachers, students, and patients who have been a part of our constant learning, erudition, and evolution. And I go by saying, Akhanda Mandalakara Vyapate Yen Charachadum Tatpade Darshit Yen Tasmai Shri Guruvendama. Thank you very much.
Thank you, all of you. Good night.
Thank you. Excellent program. Thank you very much.
Thank you.
Very nice.
Thank you very much.
Excellent.
Yeah.
Bye. Good night to all of you.
Good night.
Bye bye.
Thank you. Good
Good
night.
night.
Bye, sir. Bye. Bye. Bye, sir.